All right. Hi, this is Aza Cohen, and today we're talking about asthmatic in distress. This is about management of asthma patient in the ICU. I'll start with financial disclosures, and I have nothing to disclose. And the goals and objectives for this presentation would be to describe the risk factors for severe asthma, compare and contrast two different subtypes of severe asthma, categorize common mistakes and proper techniques of ventilatory management of severe asthma, and compare pharmacologic and non-pharmacologic management of severe asthma. So there's some interesting definitions and some arguments about how severe asthma should be defined. The topic of our lecture, the topic of our presentation is asthmatic in distress, and that's probably not the very good clinical term. So many clinical terms are used for someone with asthma who's in distress in ICU. Some of those are labeled as near fatal asthma, catastrophic asthma, life-threatening asthma, acute severe asthma. So you can imagine that these are all more or less the synonyms of the same situation, which is asthmatic in distress, an individual with asthma who's in the ICU in respiratory distress. There are no universally accepted criteria, and one of the definitions that I liked and I used in many of my presentations about severe asthma is taken from an article by Restrepo et al. From 2008, which describes severe asthma as presence of hypercapnia, acidemia, an altered state of consciousness, and the development of cardiorespiratory arrest requiring endotracheal intubation and mechanical ventilation. Now, in some instances, in some hospitals, in some ICUs, a patient with asthma, with severe asthma exacerbation, may be admitted to ICU without need of ventilatory support. But really, the most difficult variant of this presentation is the individual with asthma exacerbation who requires mechanical ventilation, which brings on a new set of problems and complications as it pertains to management of that individual. Next couple of slides will be tables taken from the same article by Restrepo et al. And here they list various risk factors that are associated with near-fatal asthma. In their article, they labeled these individuals with near-fatal asthma. So some of these risk factors are easy to guess and seem very natural to be the causes or to be the risk factors of near-fatal asthma. For example, history of mechanical ventilation due to asthma. If an individual has that history, that individual is at very high risk for development of another episode of severe asthma. Increased use of nebulizers, history of intensive care admission. So some of these risk factors on the top of this table seem very natural and seem very simple. Increased use of medications such as beta agonists via metered dose inhalers. All of that is considered a risk factor for development of severe asthma. And if you look at the little stars there, all these little stars indicate that these factors were thought to be statistically significant based on this study. Here, another list of risk factors, now risk factors not just for development of severe asthma, but for risk factors for death. And again, some of this seem very natural and easy to guess, history of exacerbations, history of intubations, and so on. But as we scroll down, we find some very interesting risk factors. Poor perception of dyspnea. Kind of has nothing to do with the asthma itself, but more with the individual's ability to perceive that they're dyspneic, to perceive that their illness, their asthma, is kicking up. We come down a little further and we find another one, low socioeconomic status. Seemingly, they shouldn't have any relationship with asthma, certainly not relationship with death, but according to the study, that was also closely associated with risk factors for death in patients with near-fatal asthma. Another interesting one is illicit drug use. And we're going to try to hit some of these, the common ones, as well as unusual ones in terms of risk factors, as we discuss this topic a little further. I like showing this table. It's from a different article now, also from 2008, but from a different article. I like showing this table because it represents some disparities in asthma mortality. And disparities when it comes to race and ethnicity, because some of those individuals of various ethnicities have different rates of asthma mortality. So here we have females versus male individuals having much higher likelihood of asthma mortality. So one is being considered as baseline level, and females are at 1.6. For some reason, Mexican individuals have less chance of asthma mortality, but Puerto Ricans have much higher. When it comes to Hispanic population, the total number, the average number for all Hispanics, also elevated. Non-Hispanic blacks, very elevated. And you can sort of cut through this table, look at various socioeconomic status or various ethnicities, and see how they compare in terms of their likelihood for asthma mortality. Total number per 100,000 population was 1.4. So you can see how various ethnic groups fared compared to others. Why should that happen? Well, there are a couple of explanations for this. Certainly, there's an explanation of ethnicity and race playing a role, in a sense that individuals of certain ethnicity or race may have genetic predisposition towards asthma development, and therefore will be at higher risk for asthma exacerbations and therefore deaths from asthma. We must think about availability of care. Kind of goes back to socioeconomic status, whether or not the individual with asthma, regardless of their ethnicity, whether or not that individual has easy access to medical care and easy access to get bronchodilators, get steroids, etc. Very interesting one. We kind of alluded to this in the previous slide. Disease perception. Are certain individuals more likely to perceive their illness or perceive that they're short of breath, perceive that their asthma is kicking up earlier in their illness, seek medical health earlier in the process, and perhaps come out with better outcomes than others? Is there something about individuals' ability to perceive their own symptoms? Pharmacogenetics is very important. Again, certain ethnic groups, certain genetic predisposition towards the bronchodilator sensitivity, and very debatable socioeconomic status. So certainly there is disparities in asthma death across these variables, and it's important to remember these variables as we take care of those patients. As Al mentioned in my introduction, I used to work in Newark. I spent about 10 years there. And for those of you guys who are not familiar with New Jersey, Newark is the inner city of New Jersey and has all the beauties and benefits of inner city. So we used to call it Newark Special, which was many patients in our hospital had asthma and asthma deaths associated with drug use. So what is strict drug use has to do with asthma. The number one is physiological action of drugs. Some of these drugs, especially the ones that are to be injected, were mixed with various powders, often talc, often others, are mixed with various powders that either inhaled or injected causes severe bronchospasm. So this may be an individual with relatively minor asthma who did not require aggressive treatment of their asthma on a regular day, but on the day that they inhaled or injected those drugs, they developed severe bronchospasm and ended up in the ICU with severe asthma exacerbation on the ventilator. There's also inability to perceive symptoms, and it has nothing to do with the individual's innate ability to perceive symptoms. It's more about if you're high on certain drug, you may not be able to appreciate that your asthma is getting worse. So these individuals kind of had a double whammy, that not only that their um, drug use caused their asthma exacerbation, their drug use also prevented them from perceiving that they were having asthma exacerbation. There was also kind of drug user profile, and this is stereotyping quite a bit, but individuals that have a tendency to abuse drugs on a regular basis had poor patient compliance, poor compliance with their medications, with their prescribed medications. They had lack of access to medical care. They probably received substandard medical care when they did receive it. There were also socioeconomic factors, and being in the inner city and dealing with certain ethnic groups, they probably also had, because they belong to those ethnic groups, they probably also had higher severity of asthma. So there is, to me, a very special profile of that inner city individual, perhaps with the drug use, perhaps with um, issues associated with socioeconomic status or with the genetic predisposition. But there's a quite distinct profile. And that kind of brings me to the discussion that not all asthmatics are made the same. And it has to do not with just inner city special, but to the fact that truly not all asthmatics are made the same. What do I mean by that? So, how do individuals develop near fatal asthma? Majority of the people will have asthma and will have gradual onset of symptoms and gradual progression of their asthma into exacerbation, and perhaps to a severe exacerbation causing airway bronchoconstriction, sputum production, shortness of breath, et cetera, et cetera. But this is something that slowly builds up, and hopefully we have time to intervene. As long as the patient comes in for medical attention early on in their illness, we have time to intervene and time to help that individual. However, there is a distinct subset of patients that have sudden onset of symptoms. They were fine in the morning, and in the afternoon they come in with severe symptoms. Either they were not really fine, they were underperceivers, they were very much sick in the morning, they just didn't perceive how sick they were, or they truly had major swing in their illness, and they were fine in the morning, and now they're on death's door, being intubated, coming into ICU in the afternoon. So yes, there is a very specific subset of those patients, either underperceivers or the big swingers in their FEV1, who end up in the ICU very, very quickly, going from normal to ICU in a matter of hours. Okay. And under the guise of underperceivers, we have individuals that are unable to perceive hypoxia and individuals that are unable to perceive bronchospasm. And like I said, the true swingers, in a sense, that big swings of FEV1, normal FEV1 in the morning or relatively normal FEV1 in the morning, and a big drop in that FEV1 by the afternoon. So there will be some subset of individuals that will come in this way. What's more important, other than just how they present, is also the mechanism and pathogenesis of their disease. We talked about the course of the illness. For gradual onset, it's days. For sudden onset, it's hours. Majority of the patients, again, will present with gradual onset of symptoms, and again, will have some opportunity to intervene in their illness early on and perhaps not let them get to the ICU, treat them earlier, maybe in the hospital, maybe even at home. But there's also other important factors of their pathogenesis. The individuals with gradual onset of illness, they have eosinophil at the center of their disease mechanism. So all the various manifestations of their illness come from the eosinophil activation. Whereas individuals with sudden onset of symptoms often have neutrophil at the center of their inflammatory cascade. So this becomes important, and I think Al alluded to this towards the end of his presentation as I was joining in the group. I think we were talking about different biologicals and whether or not the biologicals will work in asthma patient. And I don't have a whole lot of that today. I'll just mention here that most of the biologicals work on this subset of patients with eosinophil in the center of their illness. I apologize. Subset of patients with eosinophil at the center of their illness, not neutrophil. And so most of the biologicals will work here, but not necessarily work here. Also, response to treatment is relatively different between these two groups. And like I said, prevention is possible here, but kind of difficult to achieve here because these individuals really come sick very, very fast. Uh, I don't know how many of your children are going through this process of SAT exams. Mine are. But I think it's interesting to think about how this particular word plays a role in asthma. And I don't think that alexithymia is one of those words that they ask on SAT exam questions anymore. Um, I don't think SAT exams ask this type of questions anyway, but I thought that I'd kind of throw it in there to see how many of you know what this word actually means. Not only about what it means, but how does this play a role in individuals with asthma? So, alexithymia is difficulty expressing emotions and body sensations. Now, that may be important to psychiatrists and such, but when it comes to asthma, there is a very, very high incidence of individuals not being able to sense and express their bronchospasm. So they're very, very sick from asthma. They just can't tell you that they're very sick for asthma. And obviously, therefore, they're not able to seek attention and receive proper medical treatment. It's very interesting and very important to sort of think of this as their inability to perceive and express their illness. Now, going to get back down to earth and talk a little bit more about simple and straightforward clinical features of severe asthma exacerbations. And some of this is probably redundant and repetitive for most of you guys. Symptoms are that of dyspnea, cause, wheezing, and more clinical signs on physical exam are tachypnea and tachycardia, wheezing, evidence of hyperinflation, evidence of accessory muscle use, diaphoresis, cyanosis, paradoxical pulse, altered mental status. And I'm sure you appreciate that those signs that I've put them in a red font are really, really the important signs or alert signs or emergency signs that this individual is really having a hard time with asthma, and perhaps it's time to intubate them, put them on the ventilator, and put them in the ICU. There are also complications of not just the disease, but also complications of the treatment. So oftentimes these individuals, especially when they're on the ventilator, they develop high airway pressures and they develop pneumothorax, also develop pneumomediastinum, pneumopericardium, multiple other manifestations of high airway pressures and air escaping into parts of the body where it does not belong. Sub-Q or interstitial emphysema is another manifestation of that. These patients often develop mucus plugging, atelectasis, pneumonia. They develop respiratory muscle fatigue with lactic acidosis and other electrolyte abnormalities. And then treatment often leads to things like cardiac arrhythmias, especially if we use theophylline or other methylxanthines in the treatment of their asthma. Steroids often cause hyperglycemia. So many of these individuals experience complications due to disease as well as complication due to the treatment. I won't spend a whole lot of time on the pathology, on pathophysiology of this illness, what we find if we were to do a biopsy or autopsy on these individuals. It's really not something that we often see, and we do have quite a bit of success rate with the asthma exacerbation individuals, but this would be the pathologic manifestations of severe asthma. I would rather kind of skip over this real quick and get to the meat of the presentation, talking about ventilatory and non-ventilatory management, as well as pharmacologic management of these individuals. So what's the physiology of severe asthma exacerbation? How do we think of these individuals? And then how do we treat, understanding the physiology, how do we treat these individuals? It's a non-uniform, meaning not all airways are affected the same way, but non-uniform, severe, and reversible airway obstruction. The key part is reversible. Unlike COPD, we can do something about this. Airway resistance is very high, usually due to narrowing of the airway. Hyperinflation is very common. We're going to talk a lot about hyperinflation. We're going to spend a lot of time discussing hyperinflation, so I'll save that for a little bit later. We're going to talk about elevated airway pressures. All pressures become elevated, peak, plateau, PEEP, all those pressures go up. There's significant VQ mismatch. There is significant pulmonary hypertension, somewhat reversible, somewhat due to the acute exacerbation of the illness, as well as RV strain. So again, the cardiovascular system also suffers in this situation, and often there is poor peripheral circulation. So how can we manage these people? What is at our arm's length? How can we treat them? There's pharmacologic treatment for asthma, and some of this is a little bit outside of what I want to talk about. So I'll quickly run through these agents, and I want to spend more time on ventilatory management of these individuals, which I think is more interesting and more important for the audience today. So from the pharmacologic treatment, some of these are obvious ones, bronchodilators, and that includes beta agonists as well as anticholinergics. That includes short-acting as well as long-acting beta agonists. Obviously, there's a big role for corticosteroids. Asthma is very much an inflammatory disease, and we need to treat them aggressively with systemic corticosteroids as well as inhaled corticosteroids. Methylxanthines, things like theophylline, are probably the medications of the past. We don't use these medications as much anymore because we have better ones, the ones with better side effect profile. Theophylline and aminophylline and other methylxanthines, they have very narrow therapeutic profile, and they often cause systemic complications, adverse reactions. Rarely do we use these medications anymore. Magnesium sulfate is kind of interesting one. There's not a whole lot of evidence to support that severe asthma patients will benefit from magnesium sulfate, but many ER physicians will give magnesium sulfate, and there's probably very little downside from it. So I typically don't argue with them about magnesium sulfate. And then there are other medications, biologicals, as you alluded to earlier, leukotriene antagonists and inhibitors, as well as anti-IgE therapy that may be helpful in individuals with asthma. Some of these only work if there is component of allergic asthma. For example, anti-IgE therapy will only work if there is a component of allergic asthma. And again, most of these interventions that we mentioned are geared towards eosinophil and eosinophil-mediated inflammation. So if you have a patient who has eosinophil at the center of its disease, then most of these pharmacologic management will work. If, on the other hand, you have an individual who has a neutrophil at the center of their asthma exacerbation, as some minority of the patients do, then some of these medications may not be as potent against neutrophil-mediated inflammation. It's just the way it is. So again, if you have someone who has significant component of allergic asthma, anti-IgE therapy may very well be helpful for them. There's also non-pharmacologic treatment. Obviously, oxygen is considered one of them. And then helium or helium-oxygen mixture, or HELIOX, is another possible intervention for these individuals. And we'll talk about that a little bit later in this presentation. Again, the meat of the presentation will be about the ventilatory management of severe asthma, and that's where I want to spend most of the time on. Ventilatory support. There's obviously two modes, one non-invasive ventilation and invasive ventilation. Now, BiPAP is very, very, very good in patients with COPD exacerbation and respiratory failure due to COPD exacerbation. Now, one might think that since asthmatics have a lot in common with COPD patients, BiPAP and non-invasive ventilation in general will be similarly very helpful in these individuals. Unfortunately, there is a lack of scientific evidence supporting use of non-invasive ventilation in patients with asthma exacerbation, in patients with severe near fatal asthma. So I typically try not to use BiPAP for these individuals. The other problem with BiPAP is that it often masks the worsening of their symptoms. Many patients that are placed on BiPAP, in those patients, we miss the opportunity to intubate them at the right time. And I think it's very important for the asthmatics not to miss that opportunity, not to intubate them late. I'd rather intubate them early than late. And I typically try to avoid BiPAP in these individuals. Although, like I said, there's very little evidence supporting its use. Many people say, what do you have to lose by using BiPAP? But the part that you may lose in BiPAP is the ability to appreciate that the patient has kind of passed that threshold, needs to be intubated, and sometimes BiPAP can mask and delay the need for intubation. Obviously, the meat of this is in intubation and mechanical ventilation. One thing that I would like to sort of warn you against is if your patient with asthma is having significant hypoxia, if your patient with asthma cannot be managed with just a little bit of supplemental oxygen, something like FiO2 of 40% or so, 40, 50% or so, then I would suggest that you rework your differential diagnosis. There's a good chance that there's something else going on, maybe asthma plus something else or another disease altogether. Typically, patients with asthma don't present with severe hypoxia. Yes, they're hypoxic, but largely this is about ventilation. Largely this is about air movement in and out of the lungs, not so much hypoxia. Other indications for intubation should be hypercapnia, respiratory muscle fatigue, worsening mental status, and hemodynamic instability. I want to mention hypercapnia one more time. Many patients with asthma will also be somewhat hypocapnic, especially young individuals. At the early stages of their presentation, they will have PCO2s in the lower or mid-30s. By the time they're normal capnic, by the time their PCO2 reaches 40, they are already in trouble. So be very, very careful, be very, very aggressive with intubating these individuals. COPD patients, sometimes we don't intubate them until CO2 hits 80 or 90. With asthmatics, by the time CO2 is 45, it's too late to intubate, or you've delayed intubation unnecessarily. You should have intubated them when their PCO2 was 40. Here's my attempt to create some schematic representation of what happens to the airway pressures in patients with asthma. And this is true for all parts of airway mechanics. This is simply mechanics of breathing. Here we have, again, very simplistic representation of pushing the air down the airways and then expanding the lung from deflated lung to fully inflated lung. So as we think about mechanics of breathing and what does the work of breathing go on? First, we consider the peak airway pressure at the beginning of the process and plateau pressure at the end of the lung. So the difference between peak and plateau pressure will be determined by the following factors. Number one, how fast we want to push the air through the tube and what the resistance of the airway is. So here's the peak flow, how fast you want to push the air down the tube, and here's the resistance of the airways. Obviously, more the resistance, more peak airway we have to use, peak airway pressure we have to use to push the air through. Faster we push the air through, higher the peak flow, the greater the peak airway pressure has to be. This is a very important physiologic concept that's going to come back to us when we discuss hyperinflation and how to deal with hyperinflation and auto-peep. The second part of this process, again, this is very simplistic version of understanding of this process is to inflate the lung that has been deflated with a PEEP. The pressure in the deflated lung is PEEP, and pressure in the fully inflated lung is plateau pressure. So the difference between plateau pressure and PEEP typically represents lung compliance. And we often say that the asthmatic patients, they usually have a problem with airway resistance and pushing the air through the airways, and not so much with the lung parenchyma itself, not so much with the lung compliance itself. But we're going to talk about various situations where PEEP in these individuals, in addition to extrinsic PEEP, there's also intrinsic PEEP or auto-peep, and how that affects the entire lung mechanics. So again, keep this somewhat simple version of mechanics of breathing in your mind as we go on and discuss ventilatory management. So in many individuals with asthma, peak airway pressure will be high and plateau pressure will be low, representing the great difference between these two values, representing the major difficulty with the asthma, which is airway resistance. These patients are bronchospastic. This airway is very narrow, and the airway resistance is very high. But the difference between peak and plateau pressure will not be equal, but will be somewhat dependent on these two values: peak flow, how fast you want to jam the air down the airways, and airway resistance, how likely it is that the airway resists the airflow. Many patients with asthma, and I'm sure you're very well aware of that, will have high peak airway pressure. So in order to decrease high peak airway pressure, we have to do one of two different things: decrease the airway resistance, and the major component of the airway resistance is its size, and we have to increase the radius of the airway. How do we increase the radius of the airway? Bronchodilators. Now, bronchodilators will increase the radius of the airway, assuming that it's just bronchospastic. Many patients with asthma will also have some degree of mucus hypersecretion, and the airway will be not just narrowed due to bronchospasm, but also be obstructed due to presence of those mucus hypersecretion. The other thing to do to decrease the peak airway pressure, again, according to this somewhat simplified formula, would be to decrease peak flow. We're going to come back to this idea. Decreasing peak flow, or changing the peak flow, I should say. Changing the peak flow is intrinsically dependent and correlated with changing inspiratory time and I/E ratio. So if you want to change the peak flow, you're going to end up changing inspiratory time and I/E ratio. And these two things are very, very important factors in ventilatory management of asthma patient. So we'll talk about that in a moment when we mention auto-peep and airway hyperinflation. Airway resistance depends on these values. Nu here is the viscosity of the air, L is the length of the tube, and R is the diameter or the radius of the tube. So remember, we talked about how the major determinant of the airway resistance is the airway size or airway diameter, radius, basically the same thing. So the best thing we can do to reduce the airway resistance is to increase the size of the airway, bronchodilation. The second part of airway resistance comes from the type of airflow, laminar versus turbulent flow. If you have a normal flow in a large diameter tube, whether it's an airflow or fluid flow, then most of the air will have what's called a laminar flow. All different parts of the air are moving in the same direction, as represented by the arrows here. If you have a turbulent flow, the different parts of the air or fluid, it's the same for both, different parts of the air are seemingly moving in a different direction. Obviously, this is a lot easier way to flow the air and takes a lot less effort and a lot less pressure to create a laminar flow. If you have a turbulent flow, you're gonna have to use a lot more effort, meaning a lot more pressure, to move the same amount of air down the tubes. So what determines laminar versus turbulent flow? Well, there's a formula for that, and the formula is so-called Reynolds number, and that number depends on the radius of the airway. Again, bigger the airway, more likely it is to have a turbulent flow. Turbulent flow, and also depends on the velocity, how fast you're moving the air down. Higher peak flow will cause more turbulent flow, and depends on the density of the air. The density of the air is going to come back to us when we discuss Heliox later on. So if the Reynolds number is greater than 2000, there's a higher chance of turbulent flow in that situation. So again, the idea should be to limit the turbulent flow and promote the laminar flow as much as possible, as well as increase the airway diameter to decrease the airway resistance. Bronchodilation is the key because it's the most effective way to increase the radius and decrease airway resistance. A couple of words on Heliox. Why does Heliox work for individuals with asthma? Well, it kind of doesn't, because there's not a whole lot of studies supporting the use of Heliox in asthma population, but the idea is there, and idea kind of makes physiologic sense, and it's good for these types of discussions to talk about Heliox for a minute or two. So Heliox is the mixture of helium and oxygen. All of us, we breathe mixture of nitrogen and oxygen, and it has higher density than Heliox. Helium-oxygen mixture has lower density than nitrogen-oxygen mixture. And because of that lower density, the Heliox promotes laminar flow. Seemingly a good idea in individuals with asthma. It would decrease work of breathing, enhance inhaled lung drug deposition, but unfortunately there's no effects of lung function, survival, other clinical outcomes. So we kind of don't use the Heliox very often. It's also very cumbersome. I'm sure those of you who have delivered Heliox to a patient with asthma will attest that it's a very, very difficult process. The other interesting fact is that helium-oxygen mixture, the density of that mixture increases and mimics the nitrogen-oxygen mixture once oxygen concentration is greater than 40% or so. So if someone requires FiO2 greater than 40%, there's almost no point giving that individual helium-oxygen mixture because it's going to have the same density, it's going to have the same properties as nitrogen-oxygen mixture. So there's almost no point using Heliox in those individuals. So bottom line for Heliox is it's kind of a good idea, a kind of cool physiologic topic to discuss with your students, but on the clinical side of things, it's cumbersome and often doesn't lead to better outcomes. So we come to a point when we discuss dynamic hyperinflation and auto-peep in these individuals, and to me, this is one of the two big topics that I want to kind of drive home today. So one is dynamic hyperinflation, and I hope most of you are kind of familiar with this dynamic hyperinflation, which is as we breathe, we spend some time in the inspiratory phase of the breathing, some time in the expiratory phase in the breathing, and then most of us have kind of pause in between the expiration, end of last expiration and the beginning of new inspiration. There's usually a second or maybe a portion of a second, then we just pause. That time is there in case we need to, but most of us don't need that time for breathing. So these little flat lines here represent those pauses in our normal breathing. Now you can imagine that individuals with asthma have trouble with exhalation and they don't fully exhale by the time the next breath comes. So individuals with asthma here are in red, individuals with normal airway function are here in blue. So As the asthmatics continue to breathe and they develop worsening asthma, they cannot fully exhale. The air that just went in during the last breath in cannot fully come out until the next breath comes, especially when they're on the ventilator. So this leads to dynamic hyperinflation, breath stacking. So one concept, one word that we use to describe this concept is breath stacking. So stacking of the breath, one on top of the other. Now, breath stacking may be a good description, but we also need to understand that physiologically what that implies and what that means. We have air trapping. The air that went in cannot come out. So if we're talking about lung volume, we can say air trapping. And if we're talking about pressure, then we have to talk about auto-peep. So if the air that goes in the lung cannot fully come out, it causes the greater volume of the lung, hyperinflation, and it also causes greater pressure in the lung, auto-peep. So how do we see the auto-peep? How do we deal with the auto-peep? With that auto-peep also comes significant problem with the lung mechanics. Remember when we talked about how asthma is not really problem with the lung parenchyma, and then the lung parenchyma is relatively compliant in patients with asthma? Well, let's look at this graph. This is pressure-volume relationship in the lung. And most of the normal lung is on this part of the pressure-volume relationship when the lung is relatively compliant. If you imagine a lung that's hyperinflated, that's over here at the point B, now that lung all of a sudden has become relatively stiff because we need a big change in the pressure to achieve a relatively small change in the volume. So hyperinflated lung becomes a very stiff lung, not because of necessarily stiffness of the lung parenchyma itself, but because the lung has become so hyperinflated that it cannot accept any more air. So lung hyperinflation is problem typically thought of as problem with expiration, problem with exhalation, but also eventually becomes a problem with inhalation as well, because the lung becomes very, very difficult to inflate. It's so hyperinflated that it's difficult to inflate it anymore. So to some extent, the lung now has problem with inhaling as well as exhaling. So we talked about how peak airway pressure was high and plateau pressure was low, but that's only if the PEEP is low. If the PEEP is increasing because of the auto-PEEP, because of the lung hyperinflation, then all of a sudden the plateau airway pressure will start to increase as well, because the tidal volume basically equals plateau pressure minus PEEP. So here we go, plateau pressure and PEEP. As the PEEP increases, we need to increase the plateau pressure as well in order to continue delivering the same amount of tidal volume. This becomes a stiff lung, problem with inhalation, as much as the asthmatic lung, obstructed lung, problem with exhalation. So how do we treat hyperinflation? The patient that has hyperinflation due to asthma, there are different ways that we can manage the hyperinflation. Breath, again, the other words for hyperinflation are breath stacking, air trapping, dynamic hyperinflation, and so on. So which one would you use? It turns out that all of these can potentially improve hyperinflation. Which one is the best? And here, many people will say, change the I-to-U ratio. If the I-to-U ratio is 1 to 2, go to 1 to 3, 1 to 4, 1 to 6. Decrease the respiratory rate. Decrease the tidal volume. Treat the bronchospasm. That seems the obvious one, right? So yes, we're going to obviously treat the bronchospasm. But out of the three potentially ventilatory changes that we can make, which one of them is the best way to go? Write down on a piece of paper, what do you think the best way to go in this situation is, as we kind of discuss what happens. So here's the respiratory cycle. Inspiratory time, expiratory time. Inspiratory time plus expiratory time is the time that we spend in the respiratory cycle, which, if you think about mathematically speaking, if your respiratory rate is 12, you have 5 seconds on inspiration plus expiration, right? Respiratory rate 12, 60 seconds in a minute divided by 12, you have 5 seconds for this cycle. If your respiratory rate is 20, you have 3 seconds on this cycle. So one thing you can do is change ITU ratio. Make the ITU ratio lower, meaning the inspiratory time is much less than expiratory time. The cycle time does not change here. I did not affect the respiratory rate. I simply affected the inspiratory time and expiratory time ratio, or ITU ratio. Another way to deal with this problem is to change the respiratory rate. Like I said, if the respiratory rate is 20 and you have 3 seconds on the cycle, you can make the respiratory rate 12 and increase the cycle time from 3 seconds to 5 seconds without really altering the ITU ratio. So which one would you choose in this situation? If you had a patient with hyperinflation, if you had a patient with auto-peeping, which one of these modalities would you choose to decrease the hyperinflation? And the answer, hopefully you know the correct answer, but if you don't, the answer might surprise you. So ITU ratio is somewhat of a misunderstood variable, and I want to, like I said, drive this point home a little bit, even though I only have a couple of minutes left. So some of this math we already talked about, I'll skip over. Once the tidal volume and respiratory rate are set, the following 3 variables are interdependent, and I'm sure you understand this. Peak flow, inspiratory time, and ITU ratio are interdependent. If you want to change one, the other 2 are going to change. Again, assuming that the tidal volume and respiratory rate are unchanged. So if, depending on which ventilator you have in your hospital, you go to the ventilator, you usually have a dial that either says peak flow, inspiratory time, or ITU ratio. And as you twist that dial left or right, you're going to notice that you're changing not just one, but all 3 parameters. Again, assuming that the tidal volume and respiratory rate are set. The goal here is to increase the expiratory time, because as we increase the expiratory time, we're going to allow that patient to deflate their lungs and get rid of the problem of hyperinflation. So which one of these interventions leads to better increase in expiratory time? So again, let's do a quick math here. Asthmatic patient on the ventilator, respiratory rate is 15 breaths per minute, tidal volume is 500 mLs or 0.5 liters. All these other numbers are here, and I'm going to spare myself the math, or spare you the math of all this, and get to the bottom of it. If you change the ITU ratio, don't forget, you're also changing the peak flow, and we're going to come back to that in a minute. If you change the ITU ratio, you're going to increase the expiratory time by half a second. If you change the respiratory rate, you're going to change the expiratory time by 1 second. So much greater change in your expiratory time, and also a different set of problems by decreasing respiratory rate. If you change ITU ratio, you're going to run into a problem with higher peak airway pressure. Remember, peak flow, peak airway pressure, kind of interdependent, and they have a direct relationship. Higher peak flow, higher peak airway pressure. So if you change ITU ratio in this situation, be ready to have a higher peak airway pressures. If you change the respiratory rate, and this is the correct answer, the best way to decrease the hyperinflation in asthmatic patient on the ventilator is to decrease the respiratory rate. The problem that you're going to have in that situation is high PCO2 levels. So you have to choose between the 2 evils, and I suggest that you choose the evil of high PCO2 rather than high peak airway pressure. The correct answer in that scenario will be to reduce the respiratory rate. So To treat the hyperinflation, decrease the respiratory rate is the best option. Decrease the tidal volume is okay option. Treat the bronchospasm, obvious. And to decrease the I2 ratio, I would suggest that you use it very, very carefully with the understanding that it leads to high peak airway pressure. Here we come back to the same scenario, that the best thing to do in this situation is to decrease the peak airway pressure, decrease the peak flow. Remember, changing I2 ratio will likely increase your peak flow, increase your peak airway pressure. So, the basics on ventilator management: decrease peak airway pressure, lower respiratory rate, lower tidal volume, lower airway pressures. Decrease to auto-peep. Again, lower respiratory rate, lower tidal volume, lower airway pressures. Unfortunately, this will lead to respiratory acidosis. Obviously, as the PCO2 goes up, pH goes down, and we have to deal with respiratory acidosis. Not only that, patient will develop air hunger. Elevated PCO2 will be very strong reflex to increase the respiratory rate for the patient. So many of these patients will require heavy sedation and perhaps use of paralytics as well. In some situations, unfortunately, we get to the wit's end and there is nothing else we can do. So for those individuals, there's such things as permissive hypercapnia. And I read something very interesting about permissive hypercapnia, and it kind of implied how permissive the hypercapnia is. Do we let the CO2 rise, or we say we have no other choice? We capitulate and allow the CO2 to go up, because if we try to fix the CO2, it's going to lead to a vicious cycle of events that are going to cause more problems. So a lot of times the CO2 goes up by itself, and then we can't do anything about it. Obviously, if there's significant acidosis, there may need to be need for IV bicarbonate infusion to offset the respiratory acidosis, but that's a really, really, really complex and difficult patients. There's some evidence that inhalation anesthetics work for these patients, inhalation anesthetics that typically are delivered in the OR. And good luck convincing OR staff that your patient with asthma needs to go to the OR and stay in the OR overnight, because that patient needs to receive inhalational anesthetics. Another sort of kitchen sink approach, if you will, is VV-ECMO, when you can't oxygenate your patients, when you can't remove the CO2 on your patients. VV-ECMO, extracorporeal oxygenation or CO2 removal can be an option, but that's really, really, really advanced option. So I'm coming up at the end of the hour, and let's summarize what we talked about. In terms of the ventilator management, non-invasive ventilation, like I said, definitely maybe not use non-invasive ventilation. I don't like using non-invasive ventilation on these patients. If they are at the end of their respiratory distress, I intubate them before I even think about BiPAP. And remember the pitfalls of mechanical ventilation: auto-peep, I2E ratio. Pharmacologic management, kind of straightforward: bronchodilators, steroids. These are going to be the mainstay of the treatment. And if someone has something else that can potentially work for asthma patients, by all means, give it to them. And that may be some concoction in your grandma's cupboard, but as long as it's FDA approved, go for it. I think that we're very limited in pharmacologic management of these patients. It's typically steroids and bronchodilators. And when it all fails, inhalational anesthesia and VV-ECMO. I think this is the last one, and just finished a minute early. I thank you again for your attention. I thank Al and Terry for inviting me here, and let's see if there are some questions. I don't know if we're going to have time for questions, or we're going to move on to the next presentation, Terry.